Thank you, CSI West Bengal chapter, and especially Dr. P.K. Hajra for this opportunity, for sharing my experience on how to save a dying fistula. Now, as you see, I'm not a cardiologist, I'm a vascular surgeon. So most of my work deals in and around AV fistula, which is a dialysis access line. Now, the saddest part is that we are called for saving something which is dying. In probably a first world country which is more equipped, we would be undergoing a surveillance or a monitoring of our own access. It is debatable, yes, but certainly we are only called when there is a poor clearance, that is, the creatinine is rising despite dialysis. There are poor flows by the technician. He's facing problems in cannulations. There's a delayed hemostasis, something which is an index event for a central vein stenosis. If you have more time that is required for hemostasis of a fistula, you do have a strong suspicion of central vein stenosis. Then certainly swollen arms and the brunt of multiple cannulations, that is pseudoaneurysms or the aneurysmal dilatations of the fistula. Now, as an operator, what do we expect? It's not always thrombus. You can have multiple lesions, which can be in the inflow, that is the artery. It can be in the outflow, that is in the vein, and it can be in the outflow anywhere. It can be around the anastomosis. It can be in the vein. It can be somewhere where the vein dips in, that is the cephalic arch, and it can be in your main vein, that is the central vein. Certainly, once you're in that case, you need to know what the armamentarium are. It's always evolving, and endovascular is the order of the day. You can see that the surgical correction or the surgeon's role is at last, but it is still not something which is out of the list. You can have mechanical thrombectomy devices, the stents, the help of the thrombolytic agents, a simple old plasty, drug-eluting balloons, and stents, which may be even covered stents in certain locations. But what is very essential is plan well, and your planning not only starts with the case, wherein most probably you're not going to get any images. Your planning will be clinical with ultrasound. If you are lucky enough, you can have a central venogram, but certainly to have fistulograms prior hand is not very common in our part of the country, and neither it is common in the institution where I do my cases. But you'll have to plan on your ultrasound and clinically whether you want a retrograde or a brachial puncture, an antegrade in the post-anastomotic vein, or whether you want a dual access for a snaring, that is whether you want it in the groin as well as in the fistula arm. Your balloons will be mostly semi-compliant balloons or balloons which can go at least to a higher pressure. The drug-eluting balloons have a better role these days, so that should be in your armamentarium. Now, just to go through these images, see, the most common site of a stenosis is the juxta-anastomotic area. This is the artery. This is your vein. It has become hairy, and this is the most common area of stenosis due to the subtle hemodynamics. Be it a brachiocephalic fistula or be it a radiocephalic fistula, this is a brachiocephalic at the humerus, and you can just plasty the outflow vein. Yes, DEBs add to the result, but once you have opened up the vein, it gives you a better access for dialysis. The same goes for radiocephalic as well. So this again is a radiocephalic plasty, which is done with a retrograde access from the radial artery, something which is very common for people who are doing coronary angiogram, but this is the retrograde artery, the wire passed on to the outflow vein. You can't see the inflow because the blood is coming with a gush from the brachial artery, but this is your lesion, and once you have plastered it out, you do get post-plasty effects, but as long as they are not leaking, as long as they are not causing a flow defect, your job is done, because your job is to give a continuous flow, which will then help in maturing the fistula further and also giving a good clearance. But as I said, that be careful of your image. Look at this. This was a plastic case that I received. The problem is the artery, the adjoining artery also has a lesion here. So once you're doing your fistulogram, irrespective of the axis that you have chosen, you should have these three things in your local field. I say local field because there is the cephalic arch and the central vein, which is to be looked as well. But in your local field, you should have the inflow artery, you should have the distal artery, as well as you should have the outflow vein, which is your point of concern. Now, once you have this, if you've just done a plasty to the fistula segment, it would most likely either shut down on table or it will not have a good flow. You need to curve your balloon into the inflow artery so that the the juxtaanastomotic artery, the anastomosis per se, and the juxtaanastomotic vein gets dilated. So there is a role of planning or having the idea as to where you are suspecting your lesion. It's not like doing probably a peripheral angioplasty wherein you have a roadmap prior hand, but it is something which you need to know that the lesions can most commonly affect the juxtaanastomotic area of the vein and of the artery as well. Now, this is a case wherein we do a central venoplasty for the central venoplasty for a swollen limb. Once we're doing a central venoplasty, you have an option of your access as to whether you take it in the outflow vein. This was taken in the fistula going through the axillary vein, but this had to be snared down because the fistula would most likely not tolerate a very large caliber access. And the balloon that you require for a central vein is usually we step it up from a 10 millimeter to 12 to at least a 14 millimeter balloon. So it is better that you snare it and you use your groin access, because if you require a stent, then it would be better that you deploy it through a flossing technique through the groin, wherein you have a dual access in the arm as well as in the groin. But central vein stenosis is one of the most common causes of fistula failure, and something known as a recirculation, wherein your blood which is given into the dialysis line keeps coming back because there is an obstruction ahead. This is an older picture which I've picked up from my residency at Medanta. This is an over-the-wire embolectomy. The over-the-wire embolectomy catheter is not so common. This is a basilic vein transposition which had thrombus. This over-the-wire embolectomy can jolly well be done in the cath lab with an arterial access, without an open access. And once you can receive or retrieve the clot, you just need to be meticulous enough to pull back your sheath and flush your sheath accordingly so that you get a good clearance. As I said, it's not always thrombus, but you have lesions and now you have thrombus, which is getting into the way of the fistula and getting it to become a dying fistula. This is one of the cases that we've done recently at the Salt Lake unit. This was a gentleman who came with something known as a warning hemorrhage from the pseudoaneurysm of a fistula. Now, why we did extreme endovascular for this gentleman was he was 78. He had a history of cerebrovascular accident. He had a coronary history as well. He's been on dialysis for, I think, ever since 9 years. He has exhausted all his fistula options, and this is his last arteriovenous option. Otherwise, we would be looking at a synthetic graft under anesthesia, which is not probably the option to do. Now, he had 2 pseudoaneurysms which were leaking. The size was calculated. We have put in a Covera, which is a covered stent, a 10 diameter Covera. And once you have sealed this, you can puncture this area and you can puncture the other area, which is close to the bone, and you can seal it during your dialysis. Now, literature says that you do not routinely puncture the covered stent, but if this is your valuable fistula, after 3 months' time, once it has epithelized, you have no other access, you can come back and stick in one needle. It's not advisable, but there have been case reports which have been done. Now, he's 6 months on dialysis. You can see that the pseudoaneurysm has, the bleeding point has gone. It's no more red and angry. The dialysis technicians are very adept, and they have put the needle exactly where we want them to be. And he is undergoing dialysis regularly. And luck was on my side, because I thought that I would probably do a surgical correction, but then having seen the profile, I did not. And he landed up with his second CVA just 3 weeks after this. And I was pretty happy that I didn't do a surgical correction, because, these patients are really fragile and they would be best done endovascular. But having said that, nonetheless, I'm a surgeon, and there are few options wherein you can salvage a fistula surgically as well. One of them is, while you're doing an angiography, it's not always about the lesion or the thrombus that I'm looking at. As a surgeon, I'm looking at, if I cannot do an endovascular procedure, what other options do I have? Now, once you see this is the basilic vein. This is not the cephalic vein. This was a fistula done outside. I would call it as a bizarre fistula, because I have not understood what the anatomy was. Probably this is a fistula which is an eight-shepherd fistula with the artery connected to all the veins that you see. This was the main vein which was draining, but the puncturing vein was this, which in no sense of mind is good enough to take a needle. So the thing that we can do straight away is we can go in, Because this patient was stable, we ligate all the branches, take a proximal control, and just reroute this vein under the skin, which is known as a transposition. So once you do this basilic vein transposition, it is the same fistula, but it has survived, whereas it was termed that the fistula is not good enough for dialysis. And this is the post-op picture. You can see a good matured vein. There are other options wherein you find that there is a stenosis, mostly at this part, that is the distal part of the fistula, wherein we can open it up and we can correct it with a surgical patchplasty. Now, this option these days are only kept for refractory lesions, which are requiring multiple or repeated plasties. Normally, you would not like to do more than 2 plasties in a year on a single fistula. But if it is requiring a plasty, let's say 6 to 8 weeks down the line, and all the other factors are corrected, that is, you do not have any other lesions, and if only this distal part is your corrective lesion, you can go in, you can take the control and just put a vein patch on this, which is known as a distal patchplasty, which still is done, but it is very rarely done, and so I do not have pictures to share at this moment. The most common complications that you see apart from the surgical cases are hematomas, but keep in mind these are mostly self-remitting. Now, we have a study wherein we did ultrasound-guided fistuloplasty on a series of patients. They say that until and unless you have a hematoma surrounding the fistula, you have not done a successful plasty. Now, that's pretty aggressive, but just the thing to be kept in mind is that these hematomas are mostly self-remitting. If they're doing some nonsense, they would be tackled mostly with a balloon tamponade, and very rarely you would require a stent to occlude them. But still, there are challenges. The challenges is that the timely referral, where we are doing the cases, if it's in a smaller setup, it's a C-arm, which does not give good imaging, especially for the central vein. If it's in a hospital, slots are an issue because, as we know, the cardiovascular disease is just expanding. So doing something for the fistula is probably still an issue with the slots. And then once you calculate back what is the remuneration and the availability of the hardware and the energy you spend, because most of the hardwares and the balloons do not match with the coronary hardware and they need to be procured. And these are the logistical challenges, but there are challenges scientifically because the patency rates are varied. If you search the literature, they would be as bad as 40 to 80% for the next 6 months. And if you see the data, they are mostly for 6 months to 12 years. So this is not a one-time solution. This is not a one-time disease. This is not a one-time solution. And there have been studies which say that nearly 50% may require intervention or re-intervention, which is true. I mean, we cannot hide out from the fact. Then there are other challenges as to whether you pick up surgery or you do endovascular. Both are good. None is bad, but the patient is not good. He's pretty fragile. So we have to search as to what the correct option is. And then since I'm in West Bengal, there are typical challenges. If the procedure is not covered by scheme, if it is not supported, it's a chronic disease. It drains the patient. It takes a mental toll on the patient. Repeated procedures done by someone who is not still having gray hairs like me. It's a low durability in my hands worldwide as well. And the high cost, there are multiple questions. So probably, if we can formulate some kind of a scheme support or some kind of a understanding as to where a fistuloplasty cost can be supported by the existing schemes, we could probably serve our patients better. There is a logical thinking that the cost of one fistuloplasty will give me 5 fistulas or 10 fistulas, but scientifically you cannot get 10 fistulas in a single person. So the scientific idea is to keep one single fistula or an arteriovenous axis to run as long as possible. Keeping everything in mind, keeping the logistics in mind, probably this is one of the ways where you can address a dying fistula with only an outflow vein lesion by doing an ultrasound-guided fistuloplasty. We had a series of patients who had close to 80% success rate on ultrasound-guided fistuloplasty till cannulation. This was published in the Indian Journal of Vascular and Endovascular Surgery in 2016. But to keep in mind, this will not address a central vein stenosis and a cephalic arch stenosis. Thank you very much, and thank you for your presence once again.
Thank you.